She is a 30-year-old lady with history of recurrent pyelonephritis in the right kidney, and she also has a history of spinal surgery. When I first visited her, she was already on peritoneal catheter. I had advised alpha blocker as well as anticholinergics, but over the span of time, we found out that it was not making much of a difference to her misery. So she was continuously having episodes of pyelonephritis on and off. We suggested an urodynamic study which revealed high pressure, low flow. So the next step was that we encouraged her to do clean intermittent self catheterization, or in simple language, we asked her that she had to introduce a small pipe into her urethra to clear the bladder of the urine. But we admitted her also for the same so that she could be taught the how to do it. Okay, what is the correct way of maintaining a proper hygiene while doing it. But she had a spinal surgery, she had a stiff spine. We found out that it was very difficult for her even to bend a little bit forwards. So we decided that CISC wasn't a very good option for her. She most stays at home alone most of the time. Sometimes her father comes to visit her. So overall, the scenario was such that we had to do something for her which could enable her to clear her bladder comfortably. So we came up with the idea that we will offer Mitrofanoff Appendicovesicostomy. If on entering the abdomen we would found that the appendix is small in size or small in length, then we would think of doing a continence channel using small gut. On opening the abdomen, we identified the appendix. The appendix was of considerable length. It was added to the surrounding gut, and we planned on doing the adischolysis and then making further planning. So, after adischolysis, we divided the base of the appendix from the cecum, and this purple arrow points towards the mesoappendix, the black arrow points towards the appendix, and the white arrow points towards the infant feeding tube entering the proximal end of the appendix and moving out towards the distal end. In this surgery, what we do is we divide the appendix from its attachment to the gut, that is the cecum. Then we join the distal part of the appendix to the bladder by making a subdetrusor channel, and the proximal part of the appendix is then taken out through the skin by doing a YV-plasty. The patient will then catheterize this appendix with the infant feeding tube and empty her bladder. So this is the appendix. You can see the appendix. This is the mesoappendix. This is the distal part of the appendix, which is anastomosed to the bladder. You can find I have made a subdetrusor tunnel. This will act as a continence mechanism, and the proximal part of the appendix will be taken out of the skin by doing a YV-plasty.
So this is the appendix from the bladder. This is the mesoappendix. There are few fixation with the appendix with the inner peritoneum, and this is the appendicovesicostomy here done there, and this is the outlet part.
You can see the infant feeding tube passing through this continence channel. We did a cystoscopy, and this is the bladder, and you can see the distal end of the infant feeding tube inside the bladder, and that is the appendicovesicostomy pointed out with the black arrow. We then remove this old infant feeding tube, and this is the picture from outside. We introduce a new feeding tube under cystoscopic guidance just to check if there is any difficulty. So, this is what the patient then self catheterized herself, and she's emptying the bladder. She is a localite, she's from Siliguri, so she's in constant touch with me and she's doing quite well. At present, she's doing this self catheterization once every 3 hours. Thank you so much.